We cannot speak about MTM as one single disease. I have published the new myopic traction maculopathy staging system. It's not new. It was published in 2020. In this single table, you have everything you need to know on MTM, which progresses from stage 1, inner schisis, to stage 2, outer schisis, to stage 3, schisis and detachment, to stage 4, only detachment, but full detachment without schisis. For each of the single stages, you can have an intact fovea, inner fovea in stage A, or a lamellar macular hole in stage B, or a full thickness macular hole in stage C. Anyhow, this was the publication, and this is the table, just to show you the evolution from stage 1 to 2 to 3 to 4 to stage A, B, and C. So in this single table, you have all the stages of MTM. And I have published also the validation of the staging system at an international level very recently, with a very wide group of ophthalmologists not familiar with that, just to show you that it is very easy to validate and to use the staging system. So basically, in summary, you look at the retina, inside the retina, and select 1, 2, 3, or 4, and then you look at the inner fovea and select A, B, or C. And I will skip to treatment because I would like not to waste any more time. So many colleagues really give up on these myopic eyes, but I think with this technique, we might have a solution, because the literature reports that if you use only vitrectomy, the success rate is 60% as far as functional success and 80% when it is anatomical success. But it also says that for more severe stages, you can have a complete failure. So I'm telling you, this is not true if you follow the correct technique. So for most of the colleagues, this type of attachment is considered a success. I don't think it is a success because the macula is atrophic, you have a full thickness macular hole, and you might have glaucoma secondary to siliconoid. So just because the retina is attached, it doesn't mean the eye can see. These are some of my publications, but the one that I want to highlight is the proposal of management based on the stage. So this is the same slide, but upgraded with the guidelines of management per stage. In summary, the whole need an ILM flap, while schisis and detachment need a buckle. So what I propose you to do is to use a buckle since the beginning as a first treatment if you have a schisis and detachment. So the ILM flap is very important only if you need to close the hole, but if you have a detachment without a hole, you need a buckle. I started to present my buckles in 2009. At that time, actually, Carlos Mateo had not even published the first article on that, and we were speaking about buckles at the HITAM meeting in Amsterdam. And since then, I evolved the model of the buckle, as you see. I started in 2007, this model, and then I switched to a thinner model in 2011. In 2020, I started the AJL, to use the AJL buckle, and then recently I modified the AJL buckle, which is commercially available in this model you see in the bottom right picture. So this is the shape of the new buckle. It has a large arm with 4 holes, which make the surgical technique of insertion much easier. I will show you the technique in a minute from a video. I care to tell you that I am studying a nomogram to tell you at which distance to place the needle of the suture from the limbus based on the axial length. So basically, I'm studying the correlation between axial length and suture distance from the limbus. For example, in this patient in stage 3C, the axial length is 30.85. So you can you can place the suture at 10.5 millimeters from the limbus. You insert the buckle and just the suture, even the anterior, you place the suture in the anterior holes and the buckle is inside. So it makes the techniques extremely, much easier actually. It's like implanting a glaucoma valve, basically. You just suture the buckle in that specific spot with the non-reabsorbable suture, and it's over. And I have seen that instead of using a panoramic viewing system, if we use a flat lens to look at the posterior pole, it's easier because at the same time we can see the buckle and the macula. So I will show you in a minute. I am placing a flat lens on top of the macula, and with high myopia and transillumination, you can see the macula through the flat lens. It's actually easy. You can use the transillumination, but I can tell you that I tried even without transillumination. I also have the intraoperative OCT. It's very useful, but it's not mandatory to have it. So basically, this is the new technique. You just measure, you insert the buckle, and you check through the flat lens with or without the light, and it's actually much easier than it used to be. So my personal case series since 2007 is 400 macular buckles. I'm collecting the data, and I have available data on 265 over a 15 years follow-up. The anatomical success, believe me, it is true. When the buckle is placed correctly, you always attach the macula. So the variable is not the anatomical success, but it's the functional success, which is different based on the rate of atrophy that you have preoperatively, and of course, the status of the anterior media. There are complications. I think they are very acceptable compared to complication of multiple vitrectomies, but the success rate is very high. Let me show you some example. This patient with the buckle to attach the retina combined to ILM to close the hole. This is the type of success you gain, 4/10. Another example, pre-op to post-op. You see, even with the buckle, we don't want, and I agree with the EHAB, we don't want to push the retina too much. We just almost want a flat result, like in this case, as you see on the bottom, 7/10 visual acuity after 4 years with a great improvement in vision and microperimetry. So this is what you can end up after multiple vitrectomies and silicone oil usage. This patient comes to me for the second eye. With this type of OCT, I only place a buckle, and this is the end result with a great improvement in vision. Same thing for this patient, vitrectomy only in one eye. She comes for the other eye, just buckle, and this is the result, 7/10, normal IOP. This patient came with a bilateral problem. I did the buckle in the right eye, and here you can see the result. He went to another hospital for economical reason to have a vitrectomy in the other eye, and on the bottom you see the result. So from detached retina without hole, he passed to fully detached retina with the hole. So he came back, I placed a buckle, and And this is the result. So one word on development of atrophy. It's been reported that buckles develop atrophy. So this is, as you see in this picture, you see the development of atrophy, but this is not after buckle. This is the natural history of high myopia, which has been published by Kyoko Ono Matsui. Because in these patients, the atrophy develops anyway. And so I am studying the development of atrophy over a long period of time, and I don't see an increased atrophy more than in the fellow eye in the eye operated with the buckle, as you see from this picture. So the last picture that I want to share is my best patient with detached macula. I placed the buckle to reach a flat macula, and then I operated him with phaco and implanted a multifocal IOL. He can see 20/20 unaided far and near. But this is to say that this patient, if you operate them correctly, they can gain a lot of vision. So I'm done with the talk, just to tell you in summary that the anatomical success is extremely high. It helps avoiding silicone oil, and the results are long-lasting, and the development of atrophy is comparable to the natural history of the disease. Okay.
Oh, that was a stunning presentation, Dr. Barbara.
Thank you. I'm sorry for wasting your time with this technical problem. I care to say that I totally agree with Dr. El-Rayes on the fact that we need to buckle the macula of these patients, but you can choose the way of doing so. I just find, because I've done, for the 15 years, I've done macular buckles, so I think they are easier. But as he was saying, I think any one of us can be more familiar with one technique more than the other. We can compare the rate of complications. The type of buckle that I'm showing is customized, so you can change the shape. You can make it thinner and longer. You just ask the company to change. And I find it easy to implant because it basically the complications are very, very acceptable. And you can use it for any thickness of choroid and any axial length.
Thank you.